And then I'm going to...
We can hear you.
Yeah, good.
Okay.
Best practices for the assessment and prevention of constipation in conjunction with my colleague, Shaila Arana. So the way we're going to do this is I'm going to start the presentation and focus around the assessment and interventions for constipation, and then Shaila's going to follow up with the education and organizational recommendations. We're largely going to focus on the RNAO best practice guideline, but there's a couple of others we're going to mention as well. So the slide that we have up now is the WebEx features slide. We've got you muted, but if you want to ask us a question, you can type your questions into the question and answer under Q&A in the lower right panel there, and that's we'll be able to see that and respond to you. If you've just come on, we've got a poll to the right that's going to be just a bit fun for you to do. So, oh yeah, it's just the same, complete the constipation poll. So our objectives today are to provide a high-level overview of constipation, just highlight best practice recommendations from the RNAO best practice guideline on the prevention of constipation in the older adult population, and then share some resources that you might find useful for implementing the best practices for constipation. So first off, I like to go back to basics. So just what is constipation? We all think we know it, but it's basically a condition where there's difficulty emptying the bowels, and it usually has hardened feces. So we've got the Bristol Stool Form Scale. This it actually puts gradations of constipation everywhere from diarrhea to really pellet-like, rabbit pellet-like stools of someone who has severe constipation. You'll find this tool in the back of the best practice guideline on constipation. So the other thing that is what actually is constipation, chronic constipation is a self-report of 2 to 4 chronic symptoms like straining, hard or lumpy stools, incomplete evacuation, and infrequent stools. And there's not a lot of agreement in the literature about the frequency of stools. So we had a question in yesterday's presentation, if someone doesn't have a bowel movement, should we be doing an enema every day? Not everyone has a bowel movement every day, and as we talk more about the assessment, that's something that you need to assess from your residents. So a little bit of background on conditions that affect the bowels. We've got a diagram here. It shows the stomach, and then the food moves into the upper intestine, and then the lower intestine. The small bowel is where the nutrients are absorbed, and the large bowel is where the fluids are absorbed. And our bowels are really quite an intricate system. One author, he's a gastroenterologist, but he's written a book called The Second Brain, which refers to the intricate functioning of our gastrointestinal system. So it actually has as many nerves as our brains do, and it's very well connected with nerves and hormones. So basically anything that affects the conduction of nerves in the bowel is going to increase the risk of having constipation. So things like hypoglycemia, or hypokalemia, you don't have enough calcium or potassium, so it slows the muscle function of the muscles in the bowel. Neurological conditions like Parkinson's disease, stroke, paralysis, multiple sclerosis, even damage to the sacral nerve during childbirth can affect how well the nerves in the rectum respond to the feeling of being full. So these are all things that can cause constipation. Of course, colon cancer, where there's actual blockage in the colon, can make it harder for it backs up the stool, basically. And diabetes as well, with the effects on the autonomic nervous system, can decrease the gastrocolic reflex and cause constipation. There's other causes, though, because as a species, humans we're able to control our urge to defecate. So a big thing under habits and patterns is ignoring the urge to defecate. It's not a good time now, I'm going to go later. That can contribute to constipation. Abuse of laxatives is a big one. We'll talk some more about that. A lack of exercise. Exercise is really key in getting peristalsis to happen in the bowel. And so not moving around means people will have more likely to have constipation. Dehydration, because of the role of the colon in absorbing the lower colon in absorbing, or large intestine in absorbing fluids back into the body. If you don't have enough water, you're going to tend to be more dehydrated. Not moving will cause it. And also like a very low fiber diet, like we find sometimes in long-term care, or a high carbohydrate diet with lots of sugars and flours can cause that problem as well, can contribute to constipation. So RNAO's come up with a best practice guideline on preventing constipation in the older adult population. This guideline has got a few limitations that we're going to put out right at the front. It's really about what it says. It's about preventing constipation. There's not a lot in this guideline on treatments like laxatives and enemas and that to address constipation. We're going to talk about it today a little bit because we've had some questions, but there's other guidelines that we'll suggest you go to if you need more in-depth information. So the recommendations in all of the RNAO best practice guidelines are divided into three sections. There's the practice ones, which are aimed at the people doing, the nurses and other staff doing the frontline care, because guidelines are not only for nurses. There's education ones, which may cover off what healthcare providers need to know or organizations need to provide in terms of knowledge. And then organization and policy recommendations around what organizations need to do to support this best practice. So in one of the appendices 3, I believe it, of the best practice guideline, they have this lovely algorithm, and a constipation algorithm, and it breaks it up into two sections. Basically, assessment, which is what we're going to talk about first, so looking at things like the bowel history, the diet history, a medication review, functional and cognitive issues, physical issues, and then doing an actual 7-day bowel record or a diary to look at a resident's pattern or a patient's pattern of bowel movements. And then the ones around the outside, the toileting at a consistent time, increasing fluid intake, tailoring physical activity, increasing fiber, and evaluating, those are more of the implementation interventions. We just like this because it gives a really nice overview of what the part I'm going to talk about. So the assessment recommendations suggest that we need to do a detailed client history. And so we want to look at a resident's bowel habits and constipation. So that's like, when do they usually have a bowel movement? We all have a certain time of the day where we are more likely to have a bowel movement. Often that's after breakfast, and for a lot of people that's after they've had their morning coffee with caffeine. Some people they can quite time it. They know that they need to get to the toilet within about 15 to 20 minutes after having a cup of coffee. Then the measures taken to have a bowel movement like the coffee or laxatives. There's a huge issue of laxative overuse that's happened in the past, so you probably have a lot of residents who have come in with laxatives and they're using them, so you need to look at this issue really closely. People's beliefs about bowel movements, part of the addiction, so to speak, or it's not really an addiction, that's an incorrect term, but the habit of using laxatives comes from a belief that we have to have a bowel movement every day to be healthy, and that's not true. There's actually quite a variation in how often people have bowel movements. So for some people, going 2 or 3 or more days can be quite normal without a bowel movement. This whole thing is about assessing your resident. The other one you want to look at is a history of constipation or fecal incontinence. You know, what are things that caused it? Some people can be very sensitive to certain foods or drinks, or you know, it can cause them to have diarrhea. Those kind of things you want to know about. And then their ability to sense the urge to defecate. Do they know when they got to go? And and we'll talk about that more lately. So more in a little later. So these are all really the very relevant points for talking or assessing in your residence. The next thing that we want to talk about, okay, I'm going to open the poll here, and I'm going to share the poll results because I'm going to thank you for participating in the poll. Now, poll results. Okay. So the first question in the poll was, over and under medications, over half the residents take in long-term care use medications to have a bowel movement, or laxatives to have bowel movements. That's true or false. So that's actually true. And in the poll on the right, you can see, oh, you can't see. I'm not sure why you, Okay.
Share the results, Heather.
Yeah, can you see them now? Yeah,
yes.
I can see them in my backup screen here. Okay, so this is, as I mentioned earlier 2 or 3 times already, this is kind of a huge issue. The epidemiological data suggests that constipation and habitual laxative use increases with age, so more likely to see this in seniors. And there's an estimate that anywhere from 30 to 50% of community dwelling older persons use laxatives regularly, and that can increase once a person gets into an institution. So that we have to look at this. What happens with the laxatives is that they actually cause the bowels to respond less well to the urge to defecate. So the bowel has to have the extra push or the extra impact of the laxative before the person can actually have a bowel movement. There's a number. There's a number of medications that residents use to have that contribute to constipation. So the second recommendation from the best practice guideline is that you screen for risks of polypharmacy and looking at prescription and over-the-counter drugs. So a list of some of them that some drugs, it's like everybody pretty much knows about analgesics. Opioids is a huge one. We'll talk about opioids more at the end. Any drugs with anticholinergic activity, again, that affect the nervous system, like anticonvulsives, antidepressants, antiepileptics, antihistamines, antihypertensives, anti-Parkinson's, antipsychotics, pretty much any antispasmodics, all can decrease, either slow down the peristaltic contractions or decrease neurological stimulation of the bowel or decrease gastric motility. Some of the other ones, like iron supplements, can decrease the absorption of the water or other nutrients from the bowel, and that can contribute to constipation. Diuretics is pretty self-evident that by causing a bit or tending to cause dehydration, that contributes to constipation. So we have, in long-term care, it's been estimated that residents are on anywhere from 8 to 14 or more medications. So having a review of those medications is pretty important in trying to get at why a resident might have a problem with constipation. So then our next true or false question was, a resident with immobility is at risk for constipation, and most people agree with that. My little computer's not wanting to forward the slides, and that is true. So what we know is that those because the people with immobility, they're not moving as much. That slows the transit time in the bowel and contributes and makes it more likely that they're going to be in constipation. Have constipation. You need to look at things like the resident's functional abilities, their ability to eat and drink, their cognitive status. Can they communicate their needs to have a bowel movement? Can they follow simple instructions? The recommendation is more in-depth. The next part of the recommendations is to do a physical assessment. In the physical assessment, you want to look at palpating the abdomen for the muscle strength. Any abdominal masses, sometimes you can actually feel a constipated stool on the lower left side or on the left side. We don't often in long-term care as nurses do rectal exams, but it's something that if there is a problem that it might be carried on and done on sort of a second-tier assessment. The other thing that you would listen for is to listen for bowel sounds. You know, is the resident having bowel sounds? Are they, you know, what do you hear? The next recommendation is identifying the bowel pattern, and to do this, there's a 7-day bowel diary. This is one from the best practice guideline, and what the bowel pattern helps you do, and most people, long-term care homes have this built into their initial admission assessment. So you're looking to see when the resident has a bowel movement. You also, ideally, you want to use that Bristol stool form scale to judge the type of constipation. Is it, you know, sort of there's a range of constipation, and this can be quite helpful for everybody to come to an agreement on what they're actually seeing. You also want to look at the toileting method. How does this resident best go to the toilet, and then what are the triggers? What causes that resident to have a bowel movement? A lot of long-term care homes have gone caffeine-free with coffee. So if your new resident is used to having coffee with caffeine in the morning and your home doesn't happen to serve that, you could start to see, they could start to experience constipation just from that change in their diet. You also want to think of other sources of caffeine like tea, chocolate for the chocoholics in the crowd. So now I'm going to talk a bit more about interventions for constipation. So basically interventions are pretty straightforward. You want to address the contributing factors. So that's insufficient fluid, decreased fiber, regular toileting, decreased mobility due to lack of exercise, some of the cognitive issues, and then medications that cause constipation. And it's really pretty important to monitor the effect of the implementations. And most people are most homes are doing a pretty careful record of bowel movements. So it's nice if you start to make changes that you work out a system where you're actually trying to record what was the effect of that change on the resident's bowel movement. So now our next true or false question, what's everybody put? Adding fluid increases, improves constipation. So this one you might be surprised. This is generally true. And the reason it's generally true is for a few different reasons, and I'll talk about them some more on this next slide. So there's a lot more work that's been done on tailoring fluid intake. And what we know now is that fluid intake needs to be tailored to the needs of the individual resident. This is actually in the best practice guideline if you read the discussion of the evidence. So that you need to really work with your dietitian. A lot of dietitians now are most dietitians are making recommendations based on a certain number of milliliters of fluid per kilogram of resident weight, and that's really what your target needs to be, as opposed to sort of a fixed daily intake of fluid. Ways to get residents who are at risk of dehydration is encouraging sips of fluid throughout the day. Some long-term care homes have had sip and go programs, they're called, and a sip and go means that they leave fluid, usually water, at the bedside table of the resident or on their tray if they're in a wheelchair, and then everybody that goes by encourages the resident to drink, and this includes the housekeeping staff, dietary, family, just trying to increase the amount of fluid throughout the day. For increasing the fluid, you want to minimize caffeinated and alcoholic beverages because they are actually diuretics, so they're making more fluid leave than come, and you want to try to get the, limit those ones to decrease dehydration. Fluids alone are what we're calling it a multi-component factor. So just increasing the fluids for a resident are not necessarily going to cure their constipation. The fluid intake needs to happen in conjunction with increasing fiber and exercise. So our next true and false question was, adding fiber to residents' diet is a good way to prevent constipation. Pretty much everyone felt that was true, and it's most of the time it's true, and you might find that one surprising too. And the reason why we're saying most of the time is because residents who are at risk, who are immobile, might require less dietary fiber. So it's important to work with your dietitian and to come up with an amount of fiber that's adequate for resident. This is another, what we call a multi-component factor, because you really have to drink fluid to digest fiber. The best practice encourages an intake of 21 to 25 grams a day. Again, that's something that needs to be individualized. Sometimes men who are really large would need more amounts of fiber, and you can find that by increasing the fiber in their diet, you can cure their constipation. So there's different ways to increase fiber. There's a lot, many homes have used things like flax flour, which is ground up flax seeds. The reason they grind them is because some residents actually think they're bugs, and if you put them on their cereal, they try to pick the bugs out of the cereal. So grinding them up makes them more, you can mix them easier with a porridge. All sorts of fruits work really well. Prunes are well known. Apricots work well. Applesauce. In the best practice guideline in the back, there's a recipe for get up and go muffins, and so that combines many of these high fiber products together and into a muffin. You need to again work with your dietitian to gradually increase the fiber intake. It's not a situation of saying, okay, we're going to have all of our residents are going to get 2 tablespoons of flax flour every morning. It needs to be very much individualized to the needs of the residents, because some people will respond really strongly to 1 tablespoon and others don't respond at all. There is a new product out that is a dietary fiber supplement. It's that you can also consider. Some dietitians in our area in Thunder Bay here are using it. I said use caution with the bed bound, and then this is a really important job to work with your dietitian. The next one is about intervention is promoting regular, consistent toileting. And so looking at the daily routine of the resident, when is their triggering meal, and really do the toileting care plan so that the triggering meal is identified, and that everyone on the team, in particular the personal support workers or the healthcare aides, know that that's the time we've got to take this resident to the bathroom then. So that's the encouraging defecation when the urge occurs. We've got a few more slides on toileting because I think this subject's really good, and I have to thank Shyla for opening my eyes to some of the things. We really need to be assessing for individual and cultural toileting practices. So we've put with the population that we're dealing with in long-term care right now, some of them would have used the outhouse or the biffy on the left here. Some older men are used to, peeing on the side of the road. This is a common thing that we see in Northern Ontario. The fellows seem to make no bones about having to urinate there. And then for me, the middle toilet, like a squatting toilet, is a really new idea. But as Shyla pointed out to me, and we've discussed this at length, in countries like India and China, the way that they actually go to the toilet is by squatting on the floor. And so you can see in this picture in the middle that there's water available, so there's no toilet paper in this picture. So things that we take for granted in North America are not done in other countries. They actually would wash themselves with water and not use any kind of toilet paper. The other thing that to think about is the practices of certain religions. Some Muslims people still use their left hand to wipe themselves. They use the right hand to eat and the left hand to wipe themselves. So as our population is aging, and in a country as multicultural as Canada, we need to think about these things. We need to think that a resident might, a resident with dementia really might not recognize a toilet as the place that they that they would go to the bathroom, and would need to be cued about that thing. So what we take for granted, which is in this picture, is you have a toilet, and you have your toilet paper, and everybody knows what to do with that. Not necessarily if they've lost some of their, if a resident has lost cognitive abilities. They might need you to show and to demonstrate. So one of the issues is, how do you provide privacy while encouraging safety of the residents on the toilet? You want to think about this issue. A lot of people need privacy. They're used to shutting the door of the bathroom and it being quiet and nobody walking into the room. And this is a bit challenging in long-term care when we worry about residents falling, and so you need to think about how you provide that balance of privacy and safety for them. The next thing to think about is allowing enough time. This fellow's reading the newspaper on the toilet, so stimulants and diversions can help residents have a bowel movement. A more modern version of this that we had a picture of was somebody with their phone sitting on the toilet having a bowel movement. Usually 10 to 15 minutes max is what you would think of, but how do you allow a resident time when you're really busy doing, with a lot of residents to care for? These are things to think about and figure out how can you make this happen, how can you work around this. Now our next question, true or false question, was on squatting, and I like the answers to this one on the right here. It says, this is sitting in a chair is a good way to have a bowel movement, and that's false, and that's pretty, that's true, but it's quite a mixed answer, eh? So it is false. What happens when we sit in the chair is that we're actually compressing the rectum. So if you think back to the picture initially that we had up of the intestines, that by sitting down you're actually compressing, you're actually creating more likely to have constipation. So you need to try to get the person to move away from this idea that, if you've got a product on, you can just go in that. No, we don't want that. You need to sit the person on a toilet. So the next recommendation in the guideline is a squat program. It's not only sitting, but now we're going to even squatting. And this has been quite, it's getting to be a bit of a hot issue at our house at Christmas. My 20-something daughter came and told me, did you know squatting is really important? And so this little diagram here shows that how the rectum is actually a little bit constricted by sitting on the toilet. The idea of toilets for everybody, it's fairly new. Well, it goes back to Roman times, but in a lot of places in the world, people squat like this man in the lower left corner here. They're actually saying that it relaxes and straightens the rectum and makes it more likely that the entire bowel will be evacuated. So here on the upper right corner, we have a product that's trying to encourage squatting. It's a squatting stool that can be purchased. It might not be something that you want in long-term care. It's just to show that this whole idea is starting to catch fire. And I believe it was on Dragon's Den, if I'm not mistaken, this whole idea that it's better to squat. For residents who can't use the toilet, you try to simulate the squat position. You lay them on their left side because that's where that makes the bowel just a little bit straighter, and bend their knees up. You pull their knees up. In yoga, there's a position called wind relieving position where you pull your knees up as high as you can, and that will help people who are in bed to be able to have a bowel movement. The next intervention is to encourage physical activity, and the recommendations are walking for 15 to 20 minutes twice a day, or 60 minutes per week, and trying to go at least 50 feet a day. So if some of you are rolling your eyes at me and saying we can't do that in long-term care, think about it like this. Think about it that if you can help a resident walk to the dining room, that adds some exercise. There's in the activity recommendations, there's nothing that says the exercise has to be all at once. So the more that you can do to encourage people to be up and mobile and helping them during the course of the day, the better it is. Exercise is another one of these interventions. It works in combination. It doesn't just increasing exercise alone is not going to necessarily decrease a resident's constipation. The best practice guideline makes recommendations for encouraging physical activity for those who are in bed, and so you can use arm exercises, side-lying exercises. This one is from stroke.org. All of these things in the bottom, you have pelvic tilts. All of these things can help people to have get a little bit of exercise. Those are the recommendations on the intervention recommendations in the best practice guideline, and I just want to, in the RNAO best practice guideline, but because we had questions about laxative use, we've added a little bit more here about laxatives. So Okay, so the first step and this one is from the Rehabilitation Nurses Foundation best practice or practice guidelines for the management of constipation in adults. And they have step one, just what we've spent quite a bit of time talking about, fluids, fiber, exercise, and toileting. Step two is used with caution, bulk-forming laxatives and stool softeners. This is pretty much moved out of long-term care where, it used to be fairly common to be using lots of Metamucil and Colace and stuff, and now that's less and less common. So they have step three as osmotic laxatives, and then step four is stimulants, suppositories, and enemas. And the reason this is done as an inverted triangle is because you really want to use suppositories and enemas as little as possible. It is, for many, many residents, you can move them away from laxatives by working first on this fluid, fiber, and exercise. So with laxative use, I've said earlier, laxative use can cause dependency. Ideally, you want to only use laxatives after you've tried exercise, fluid, fiber, and toileting. Review the use of laxatives regularly. So when you're doing medication rounds quarterly, and definitely when you do the annual case conferences, see if you can wean the residents down. We've had homes here in Northwestern Ontario who have focused on decreasing constipation, and by increasing the fluids and fiber have really moved residents right away from laxatives and decreased their enema usage a lot. And that one way that they've used to monitor this is to actually just use the bowel records, count how many enemas and laxatives they're giving, and it's a very simple, straightforward way to decrease the use of the laxatives. One of the questions that we had was, how do we get residents to take laxatives? So that's a bit beyond the scope of this. We'll just say a few words about it and direct you to the reference we have in our list of reference there. We found some interesting information in the Alzheimer's Compendium. And so, first of all, when a resident's not wanting to take any pill, you need to see if first figure out, is that causing a problem? Are they having actually an adverse reaction to that pill? And figure that out first if they have a problem with it. And then other suggestions that from caregivers, it's been like provide cues, make it a non-event, don't force people, just hold it out, make a game of it. One suggestion that might work with people who have earlier dementias, get a note from the doctor saying the doctor wants you to take it, try bribing it, hiding the medicine in anything edible. I think we do that lots already in long-term care. A newer one is talking with a compounding pharmacy. There's a cost to that, but compounding pharmacists can put medications into absolutely everything, or almost everything, I think. And there's, it may be something that that a resident, if the family's willing to pay for it, that could be used. But anyway, you can just look further into references for that one. So then the use of laxatives, because this again came up, just use them as ordered. You only give a suppository enema if the laxatives are ineffective. Somebody said, when is the best time to give a suppository or an enema? And they work about 15 to 60 minutes after they're given. And if you want to retrain someone's bowel, I'll talk about that in a minute, it's ideal to give that at the time when they would normally defecate, so or give it 15 to 60 minutes before the resident would normally have a bowel movement. One of the questions we had is constipation caused by narcotics, and again, this is beyond the scope of the guideline, of the RNAO guideline, and from what the review that we did, evidence is pretty limited on what to do about constipation caused by narcotics. There was a Cochrane review on it a few years ago. It got really mixed results. The review from Harvard suggested that laxatives are required. If you look on some blogs and stuff, people who are taking opioids in a long-term, for long periods, say that they very much focus on fluid, fiber, and exercise. So all of these are possibilities, but this is something you really need to talk with your team about. You need to bring the physician in. You need to bring the dietitian in. It's a real challenge. Interesting with all the opioid use that's increased in our society. There's something now called narcotic constipation. So I encourage you to keep looking for more information on that. The reference that we've put into the guidelines is from the Scottish Palliative Care Guidelines. And again, because often this problem occurs when people become palliative, they have recommendations there on more specific on how to go about addressing the problem. One of the questions we had was on bowel retraining. So this is a situation when a resident had, maybe overused laxatives and wants to retrain. So again, this is beyond the scope of the RNAO best practice, but the University of North Carolina has a Center for Functional Gastrointestinal and Motility Disorders, and they have a lovely handout on it. So we've just adapted this one and put a reference to the handout in the references list. And so basically what they say is find the regular time, which we've talked about. This is going to be reiterating my part of the presentation. Let the person sit on the toilet for about 15 minutes. Do this, have the caffeinated coffee. If there's no bowel movement, get up and do regular activities. If no bowel movement for 2 or 3 days, then use an enema. Continue with the daily laxatives, and avoid becoming frustrated. You've got to keep trying alternatives. And so that's, again, that's one way to do it. So the last under interventions, you want to evaluate interventions to ensure they're effective. So monitor the residents' responses to your interventions, update their care plans, follow up with referrals to dietitians, the physician, and document and monitor the bowel movements, which I know most homes people do pretty religiously. Now I'm going to turn the presentation over to Shyla.
Thank you, Heather. I just want to address a question from Amanda. Thanks, Amanda. Yes, Amanda's question is whether we will receive these slides. So I just put my email address in the chat box there, if you can make a note of it. Yes, this presentation will be sent out in handout form to you if you've attended and pre-registered. For those of you who have, I do not have your email address if you've not pre-registered, kindly email me if you do not get it by the end of today. You may also contact your RNAO long-term care best practice coordinator who will be sharing this handout with you. So for those of you who did not catch up with frantically taking notes, no worries, you will be getting this in a handout. Now let's move forward with the education recommendations. And the education includes teaching about the importance of identifying the residents who are at risk for developing constipation, utilizing health measures such as exercise, hydration, dietary fiber, along with timely response to the urge to defecate that Heather emphasized so much. Education should be planned not only for nursing staff, but for all healthcare providers, as well as for residents and for their families and caregivers. And I say caregivers here because there may be non-family companions who spend most of the day with the resident, and they could be a part of preventing constipation as well. The education should address how to reduce constipation and promote bowel health for the resident. You must take into account the general factors and, more importantly, address the individual situation of the resident. Education should also focus on the development of individuals on the bowel management team and committee, because this would be at the program planning level, the monitoring level, and evaluation of your bowel management program. You need to learn to evaluate the effectiveness of the general consideration of the bowel management program, as well as the effectiveness of the individual resident intervention on preventing and managing constipation. So there is literature in long-term care homes that shows constipation prevention champions play a role. These may be resource nurses who have a role to disseminate the information, and these will be champions because you are the ones who are the first line here with the resident and will be able to identify the issues primarily and have that opportunity to do that incidental teaching as well. So the next two slides is on the educational topics that you could include. So you may already have, if you read through this list, you would have, may have already addressed these topics with your teams and residents and families. And if not, if there are some that are pending, then you may want to include them on your priority list for education with residents, families, and staff. The content has been included in the presentation so far, and I will be also sharing with you supporting education resources that will help you cover some of these areas. So as you see, there's a comprehensive list. So I want to take you to one of the resources, which is the second edition of the LTC Toolkit. This has been developed for long-term care homes by my colleagues across Ontario. And there are several clinical topic areas. There are 10 different topic areas. For our purposes this afternoon, I wanted to point out the topic on your right side part of the slide, which is on continence care and bowel management. Here you will find several resources categorized under different resource types. So I'll point you to some of the education resources here that are available and ready for you to use. So on the next slide, as you see here, the teaching learning resources are the learning materials for the continence and constipation workshop for RNs in long-term care. Now, as you see, the topic is coupled along with continence as well. This supports implementation of the RNAO best practice guideline on promoting continence using prompted voiding, as well as on the prevention of constipation in the older adult population. The workshop outlines three resources as part of the workshop. It has facilitators package, the participants package, and also a slide presentation. It also gives you an understanding of the different tools that Heather has pointed out, such as the bowel elimination record, the Bristol stool form scale, and also it includes interesting activities such as crosswords, case scenarios, so that you can mix it up and make it interesting for the audience that you're educating. For residents and family education, we have the RNAO fact sheet, which is Constipation Prevention is Key, and a second resource, which is the BP Blogger, Mythbusters About Bowel Issues, Fecal Incontinence and Constipation. These are available in the LTC toolkit under Continence Care and Bowel Management. Now, you could use these as is. You could also leave them in the staff lounge, in staff dining areas as well for leisure reading, or you could use some of the information from this and the best practice guideline to help you develop or customize a resource for your own home. Next, we walk through the organizational recommendations. And it's really essential that you do have the support of your organization to implement this best practice guideline. So contributing factors for constipation may include functional deficits, mobility problems, environmental barriers, sensory deficits, dietary and hydration problems, as well as chronic disease processes, polypharmacy, mood, cognition, and social issues. So as you see, an interprofessional team approach to constipation management is highly recommended. The members of the team may include your unregulated as well as regulated professionals. Each of us have a role to play. So, for example, the nurse would conduct the initial assessments and reassessments and develop behavioral treatment plans. They review and evaluate the interventions and its effectiveness and revise the plan of care accordingly. Our PSWs support hydration, toileting, hygiene, and managing constipation and incontinence. They're often the first ones to identify problems with constipation. Our other interdisciplinary team members are the physiotherapists who would assess mobility, transfers, balance, and strength. Activation assistants assist keeping the resident active, mobile, and maintain the balance, muscle tone, and strengthen the muscles through activity programs. All these contribute to prevention of constipation. Your occupational therapists assess the physical and social environments, including each resident's ability to perform the activities of daily living, something that we may not think is as important, but managing to take off and put on the clothing is really essential when it comes to toileting. Clinical pharmacists assist with the medical review of to identify medications that may be contributing to constipation, and our registered dietitians advise regarding modifications to fluid intake, caffeine intake, fiber intake, etc. Our physicians have a major role to play here as well, and they may refer to any of us on the healthcare team, health professionals, to assist with managing the incontinence as well as constipation, because sometimes they may be connected. Physicians may identify also any serious problems. If you're struggling with managing constipation, it's always a nice idea to consult with the interdisciplinary team to see how problematic this is, or is it a serious complication. And communication is really essential with this interdisciplinary team across, and continued communication about this resident. With the organizational support, the next recommendation is that the best practice guideline can be effectively implemented only when there are adequate planning resources, organizational and administrative support, as well as appropriate facilitation of the change process by skilled facilitators. And that's where the education part of your team comes into play. To implement the best practice guideline on prevention of constipation in the older adult, take into account how it will apply to your organization, your bowel management program, and what you will need to have an active educational and training program to address, which you saw in the previous slide. The next important resource here is the gap analysis, which is a process where you can compare your organization's current practice with evidence-based best practice recommendations. This document is a Word document available to you on the LTC toolkit under the organizational assessment category. You could use this tool to see where your organization is at, as well as to recognize things that you are doing well, because they may be, you may be meeting some of these recommendations, or some of these recommendations may be partially met. It calls for celebration with your team when you recognize this as part of your bowel management program. Here, you could use this in your quality improvement initiatives when you identify recommendations that are unmet, and prioritize as to whether it's going to be fulfilled in a year or it's a multi-year project as part of your quality improvement initiative. With the next slide, as you see, your gap analysis will help you to address some of the requirements of the Long-Term Care Act. So as you see here, the Long-Term Care Act does require you to have an interdisciplinary program. The gap analysis serves as a written document to fulfill these requirements. You'll be able to set out goals and objectives, and also develop recognize to develop relevant policies, procedures, and protocols. It also helps you to use provides you with tools so that you can identify indicators for your program and work towards achieving them. And your Ontario regulations as well, which is important, are the treatments and the interventions to promote continence as well as constipation. And these can be included in your bowel management program. So do use this gap analysis to help you identify these things. Now, with that being said, just as a conclusion, constipation is everyone's problem. It's usually preventable, so that's where we want to address it. And it's up to us now to develop those individual care plans and adapt to the residents' needs. It's question answer time now. We have about 5 minutes before the close of our webinar. And so if you could kindly type in your questions in the Q&A panel, we'll be happy to answer them.
And I've also, Charlotte, put the poll up, so if you could give us feedback, this really does help. We like to know things that went well and didn't go well for you. Are you going to open the phone lines as well, Shyla?
Yeah. So we'll look out for the Q&A in the chat box, or sorry, the Q&A panel. And also, if you prefer to unmute your line and ask your question, press *6 and give it a moment and then ask your question. Like Heather just mentioned, please take a moment to complete the poll. Your feedback is very valuable to us. *6 to unmute your line and ask your question.
Maybe while we're waiting at the end, I'll just put go over some of the references. I mentioned that Alzheimer's Compendium on helping Alzheimer's patients to take their medications. Then the Rehabilitation Nurses Foundation Best Practice Guideline. It's more in-depth. It really focuses around people who have, paralysis and other problems that rehabilitation nurses would find. And then on the next page of references are the ones from the Scottish Palliative Care Guideline and then the University of North Carolina, just so that you've got those in case those were some of your questions. Okay, so we've got in the chat box a question. For the person, let's see. For the person who's probably trained themselves to go longer than 3 days to have a bowel movement, should they be started on laxatives as this is a practice? Well, that's a good question. I think what you need to do is really focus on start off with that assessment and what's the resident, where's the resident coming from? What's the resident's individual pattern? I mean, they may or may not have trained themselves to go. Some people just, bowels don't move that often. And we need to recognize that our residents are individuals, and certainly that's in keeping with the Long-Term Care Act and best practices for patient and family centeredness, is that you have to look at what's working for that resident.
Thank you so much for joining us this afternoon. If you think of any further questions, feel free to contact us or your long-term care best practice coordinator.
Yep, thank you.